Hello, everyone. Welcome. Thank you for being today with us. I'm Andrés Pascual, and today I'm going to be the moderator of a session of the Bone Regeneration Online with the sponsoring of BioHorizons Camlog. Today we're very happy. We have three magnificent speakers, and the session topic today is going to be about novel regenerative concepts, biological, rationale, and clinical applications of a new dermal matrix, Novomatrix, in soft tissue augmentations and GBR indications. So far, we can say that the development of the summit is being a complete success. We have lots of attendees from different parts of the globe. So thank you, everybody, for connecting today here with us. First of all, we're going to enjoy a presentation by Dr. Tony Sculean. His topic is going to be about a comparison of our different porcine-derived collagen matrices for soft and hard tissue reconstruction and their wound healing potential. Dr. Sculean is a professor and chairman of the Department of Periodontology and currently the executive director of the School of Dental Medicine in the University of Bern in Switzerland. He has achieved several awards and recognitions in the field of periodontology and dental implants, and so far he is an author of more than 400 articles related to these topics. So, Dr. Sculean.
Yes.
Hello, Tony, how are you?
Hello, great, nice to see you.
Thank you for being today with us.
Thank you so much for chairing this session, and hello everybody. It is really a great honor for me being here with you and having the possibility to share with you some of our data. And I will start with the topics that we would like to address. Namely, I would like to present some data on the interactions regarding the different matrices that we have for soft tissue cells, some data on bone cells, and also to point to some clinically relevant aspects before making some maybe some conclusions related to the outlook in the future. So first of all, what is very important to know is that when we talk about periodontal regeneration or also bone regeneration, soft tissue regeneration, doesn't matter, regeneration in the oral cavity, we have to deal with a number of very important growth factors that play a pivotal role in the wound healing, namely transforming growth factor, fibroblast growth factor, different isoforms of the platelet-derived growth factor, PDGF, then the growth and differentiation factor number 5, GDF5, and bone morphogenetic proteins, for example, BMP2. And of course, these growth factors interact with each other. However, they are very difficult to be kept in the wound, and they have a rather short half-life time. So for this reason, it makes sense to use a certain carrier for these growth factors. And one example is the collagen, because the collagen, as we very well known, is a main component of the connective tissue. Usually the collagen is fully biocompatible, it is biodegradable, it provides a support for the structures. However, it can be in two major forms. It can be either in a native form or in a cross-link form, which further improves the mechanical property. And it is very important to know that collagen facilitates and stabilizes the blood clot and has also a kind of hemostatic effect following a wound production. It may attract cells of different phenotypes. And a very important aspect is that it serves as a carrier for growth factors because it binds growth factors from the fluids available in the wound. So we have now for the soft tissue regeneration a number of matrices that can be used and have been already introduced in the daily practice. For example, a non-cross-linked collagen matrix, abbreviated as NCM. We have also some sugar cross-linked collagen matrix or matrices abbreviated as CCM. Then we have an acellular dermal collagen matrix that is supplied in a dry form. This is abbreviated as DADM. And quite recently, we have also a novel so-called prehydrated acellular dermal matrix that consists of tissue-engineered porcine material. And in our studies, we abbreviated it as HADM. And in the first study, we wanted to know whether these on the market available matrices may have the property to absorb the different growth factors that play an important role in the wound healing, and whether they can keep these growth factors over a certain period. And we know from different wound healing models that the first 2 weeks after wounding is very important. So that's why we selected this period of roughly 2 weeks, and whether these proteins can be released. If you look now on this screen and you see the 5 different tables regarding the concentration of the various growth factors that I mentioned before, you will be able to see that all 4 matrices have this property. They absorb the proteins very fast, the proteins up to 90 or 99%, and they will release these growth factors over a period of roughly 13 days. However, if we look now at the different peaks, you can see that the growth factors are released from all matrices. What we observed, if we compare the 4 different matrices, and that you can see here in the bottom left small table, is that the hydrated acellular dermal matrix releases a higher amount of proteins in a so-called phase 2, and this amount was roughly of about 80%. In other words, it seems that this matrix absorbs the proteins. However, the first peak after a couple of hours and days is not as high. However, it is maintained on a long-term basis, and even after 13 days, these proteins are released, indicating that the wound is full or maybe full with proteins even after this period of time. And this is very important. You can also look now, for example, on the release of PDGF. And the PDGF, we all know, is a very important factor responsible for the early wound healing, especially for the ingrowth of blood vessels. And again, if you look at the last part of this table, you can see that 82% of these growth factors were released by a second peak, and especially the highest peak was observed again after the use of this hydrated collagen matrix. Now, if we look at the BMP2, it is very important to see the difference. And look please again at this small table at the upper right corner. We have the 4 different matrices, and we can see that all 4 matrices release the BMP2 up to a couple of days and weeks. All 4 have 3 phases, but one important observation that we made is that the hydrated acellular dermal matrix has even a phase 4 That means that even a more prolonged activity in the release of BMP2s. And this is very important, especially if we may consider later the effects on bone healing, okay? Because we know that BMP2 has a very important effect on bone healing. So we summarize these conclusions, and we know that these matrices are able to intake these proteins, the growth factors, and they release them over a period of 13 days. However, some matrices seem to perform a little bit better than other matrices. And if we look at the matrix of the new generation, namely the hydrated acellular dermal matrix, has consistently shown a very high amount of proteins and protein release within hours, but it was followed by a prolonged secondary phase. And this was characterized by release of high quantities of pro-migratory and pro-proliferative growth factors like TGF-beta1, FGF2, and PDGF-BB. And compared to the other matrices, this hydrated matrix has shown the highest release of the osteogenic BMP2 factor because this was a very important observation and may bear also clinical relevance. Then, of course, we wanted to know what is going to happen with the cells. What kind of cells are present in the wound? Of course, we have soft tissue cells, for example, parental ligament fibroblasts, or we have also gingival fibroblasts. And we wanted to know how is the behavior of these collagen matrices when they interact with these cells. So please look at these stainings, these dark blue stainings at the left bottom corner. We have the control, and then we have these dark stainings, dark blue stainings. The darker the staining is, the higher the number of cells, the density of cells, indicating that the cells love these surfaces. And you can clearly observe that the hydrated collagen matrix and also the cross-linked collagen matrix, that was, one was the Novomatrix, the other one was the O6 Volumax. You can see that they seem to increase quite strongly the density of the cells. And you see also the summary of this on the graphs. And please observe that the red and the orange graph perform quite well, and always a tendency of a higher performance of the dark red graph is visible. And then we wanted to see in a so-called wound scratch assay the wound healing potential of these cells. So how do we do such an experiment? It is a standardized model that is very well known in the literature. So you place, in fact, the membranes and the cells on a plate, and then you can take a blade, a microblade, and under the microscope, you can make a wound, a so-called scratch. And then what you do is nothing else but to watch and to measure the cells that are going to cover the injured surface, okay? And as fast as they grow, you can also measure. And in fact, if we look at the recolonization of the wound with the cells, again, you can see that the red graph, the hydrated acellular dermal matrix, and also the cross-link, the collagen matrix, improve the wound coverage in a higher percentage compared to the other matrices. And it amounted ligament cells and oral fibroblasts, gingival fibroblasts. Then you can see again these two graphs, the red one and the orange one, seem to be higher, especially compared to the black one, because that's the control. And then we looked also at the increased expression of proliferative marker genes in these cells. And you can again look at these graphs and you see again that these genes are upregulated at a higher level if you look at mainly the hydrated collagen matrix and the collagen, the crossing collagen matrix, but the tendency always showed towards the red bar. And when we look now at some increased expression of adhesive marker genes in human frontal ligament fibroblast and oral fibroblast, then again we can observe that this analysis revealed a significant upregulation of all 4 adhesive genes over these matrices. However, a tendency was observed towards the hydrated matrix. And then we looked also at the wound healing related genes. We have a number of genes that you can see in the screen. And if you look again at this upregulation, you can see that also the other matrices perform quite nicely, but the tendency is always a little bit towards the red one. So what we can see is that the hydrated acerodermal matrix, but also the CCM triggered a stronger migratory response compared to other 2 matrices, to NCM and DADM. And the cells grown on CCM and DADM demonstrated significantly higher proliferative rates compared to cell grown on plastic. And that was the control, of course, and the two other membranes. And the proliferative effect of the matrices was supported by the expression analysis of proliferative markers regulating cell cycle progression. And this may indicate that these matrices have, in fact, a prerequisite or achieve a prerequisite for good adhesive properties of the 4 scaffolds, ensuring proper cell matrix and cell-cell interactions. And they offer a very good basis for accelerated vascularization, especially for the hydrated acerodermal matrix. And then let me show you one quite recent study that was published a couple of weeks ago in a very good journal. And we wanted to see what is the effect on bone cells, okay? Because we have also a very important component related to the bone. And of course, for this, you can have some standardized precursors of bone. For example, the mesenchymal stromal ST2 cells or the preosteoblastic MC3T3E1 cells. These are standardized models known in the literature. You can see the mechanism on how these cells may develop into the osteoblast or into osteocytes. And we wanted to see whether the membranes or the matrices may influence this. So again, we looked at the osteoblast migration over these membranes, and what you can see at this screen is again the HADM. You can see the hydrated acerodermal matrix performed the best. You can see the dark blue color has the strongest intensity over this, especially compared to the control, but also compared to the other ones. And you see the same features that are shown in the graphs. You see it in the cell-covered areas. And when we look now at the relative mRNA we compare the 2 precursor type of cells, we see that the tendency goes always towards the novel generation of matrices. So what we concluded is that strongly induced proliferation of osteoprogenitors was observed, especially when they were grown on HADM and CCM collagen-based matrices. And you can see the summary of these findings. And this was published in the Frontiers of Bioengineering and Biotechnology, a very respected journal with a high impact factor. And when we look at the increased expression of osteogenic differentiation in osteoprogenitor cells grown on these matrices, again, the novel generation performed very well. And please observe again the tendency. And of course, these experiments were repeated a number of times. It's very important to be consistent. And this is very, very important to be reproducible also by other groups. And then a very important finding or a new thought that we had is a so-called biofunctionalization of these matrices. So what does it mean? It means that we may soak these matrices with certain biologic active molecules, for example, with EMD, this is enamel matrix proteins, or we can also use some growth factors, BMP2, or we may even discuss the use of PRF combined with these matrices. And if you look now at the biofunctionalization properties, you can see that if the membranes are biofunctionalized with this, with different methods, with different type of growth factors, they perform better. All of the membranes perform better. But if you look now at the hydrated collagen matrix, it seems that there we have also a kind of additional increase. And it seems that, of course, we need also to have a material that doesn't disintegrate in a fluid. And I will come back later to that. Also, if we looked at some other markers like Rungstow and ALPL that are very much responsible for the early formation of bone, and we code these matrices, then we can again see a tendency of additional improvement in terms of bone formation. That's very important. So what we attempted to draw as a conclusion for later, maybe clinical indications, and this we can discuss later, is that in vitro effects on osteoprogenitor cell behavior was observed for all four matrices, pro-migratory, pro-adhesive. However, this may be biofunctionalized by using the various biologics. Let me show you only some clinically relevant informations. I started to use this matrix in my patients roughly more than 1 year ago. Of course, this is not a bone regeneration, it's soft tissue regeneration using the tunnel approach. And this is the material, the Novomatrix. What is very important to point out for the clinicians is the handling. I think that that's very important. We have many materials with excellent biologic properties, but we also need to use them in the clinic. And it is very important to use the material as a kind of collagen matrix, as a kind of connective tissue graft. And I use it for soft tissue augmentation. You can see here the tunneling approach. And I use the modification of the tunnel approach. I don't want to go now into details, but it feels like autogenous tissue. That was maybe the most striking observation that I had. And this is really unique for the material because this you cannot have with any other material on the market, of course, excepting autogenous tissue. This is one example of the outcome. And I have a couple of minutes left, so I will show you a more video just to illustrate how I'm moving on. You see, this was a patient that I treated in a live surgical demonstration, and she had recessions from premolars to premolars. I just want to show you how I prepared the tunnel. This was a quite extensive surgery. It was a young lady that had this quite extensive soft tissue defect. You see the preparation of the tunnel. I like to use this technique. And then I move, in fact, I just want to show you the technical tricks that I can recommend to you. I always hydrate the matrix and look at the length of the graft that you can obtain. You can see covering the entire area. And I can tell you that if you have to harvest that much connective tissue, it's not that much fun for the patient. Maybe it's more fun for us as a clinician, but for the patient, definitely maybe not the best. And look at the handling of the material. I think that's quite important to point out. You can suture it, and it has a mechanical stability. It doesn't rupture. And this is very important. And if you look now at the bleeding, you can observe that the material absorbs the blood from the surrounding tissue. And what do we have in the blood? We have growth factors, obviously. So we have the growth factors, and we know from our studies that these growth factors are going to be kept in the wound, and they are going to be released over a period of roughly 2 weeks or even longer. Of course, we need to stabilize it, and I can tell you that I have worked with many matrices, but the problem is with many matrices is that once they absorb the blood, you cannot suture. And probably many clinicians would agree with me. And that's why I think that not only the biologic property is important, but also the clinical handling is very important. And this is a very, very important point to be stressed. And you can see now, I don't want to show you now all the area, but please observe here the coverage of the graft. I like to cover it completely. And you see I did a surgery from almost from first molar to first molar. And let me show you now the early wound healing. That's about 2 months later. Looks very nice. And also the color is very, very natural. You don't see the difference between the pristine side and the treated side. So let me come to my conclusions. So I think that we have data to conclude that new collagen matrices may represent a future option, either for replacing autogenous tissue in certain cases, but even more to serve as scaffolds for biologicals, or maybe even for cells. I think that's very important. So we may even combine autogenous tissue, a small portion, with a scaffold, with a collagen matrix. And I would like to emphasize again this expression of biofunctionalization, because I think that this may have clinical relevance for the future. First clinical results indicate an excellent tissue response following the use of Novomatrix. For recession coverage, I have treated roughly about, I think now about 20 patients. And especially if you use the tunnel approach in order to maintain an excellent blood supply and you don't have a tension in your flap, in your tunnel, then it seems to offer an excellent heal. The preclinical data point also to the potential relevance of Novomatrix for bone regeneration, because you have seen that we had excellent outcomes, not only on soft tissue, but also on bone, which may indicate or may suggest that this material could be used not only to augment the soft tissue, but also to have a kind of membrane for guided bone regeneration. And I know that Tiziano has some wonderful material on that. He's very smart clinician, so he had exactly the same thought as we had. And I think that these findings go hand in hand, and I'm looking forward to the discussion. But I think that this is a very important point that should be addressed in further research. So thank you very much for inviting me, and I hope that I was able to give you some insight in the biology behind these matrices. Thank you so much.
Professor Sculean, thank you very much for such a sharp and straight presentation. You definitely show some revealing and novel information, providing us with data that might lead to the information that we need to understand which of the matrix that we have in the market is the best for each situation. I will ask you please to stay connected with us, because at the end of the session there's going to be a roundtable and we will discuss a little bit further into some of the data that you presented today. Before I present you the next speaker, I would like to remind you that there is translation. We have Spanish translation and Italian translation for each of the speakers. And also there is an open chat where you can leave all the questions and the doubts that you have, and we will translate them to the speakers at the end of the session. Our next speaker is Professor Tiziano Testori. Thank you, Tiziano, for being here today with us again.
Thank you, Andrés.
I would like to introduce you to Professor Testori. Professor Testori is currently the head of a section of implant dentistry and oral rehabilitation at the Galeazzi Institute in Milan. He is also an adjunct clinical associate professor in the Department of Periodontics and Oral Medicine in the University of Michigan in Ann Arbor. And as all our lectures today, he is also a writer and publisher of more than 150 articles. And it is a pleasure to have you here with us today. The topic that Professor Testori will speak today is about the clinical use of a new acellular dermal matrix, a new vision in soft and hard tissue management. Professor Testori.
Thank you so much for the kind introduction. Thank you so much for the invitation. It's a real pleasure to be here with you, online, broadcast all over the world. My topic will be another regenerative concept of biological rationale and clinical application of these new matrices. And I should make some disclosure, as you can see here. And I would like to thank you, even Lake Como Institute, and all the team at the Lake Como that helps me in prepare clinical cases following the patient. So it's a combined effort that we share here as a team, as a group. My topic will be divided in 3 different sections. A brief literature review to address the question, do we really need to have soft tissue around our implants to have soft tissue stability, hard tissue stability? Do we have objective tools to validate or to diagnose the thickness of the periodontium? And we will see some cutoff values that are very clinically relevant and important. We will see some clinical use of these new matrices, and we can draw together some conclusions. Regarding the literature, we can say that the latest information, we see that the evidence available nowadays support the use of soft tissue augmentation procedure to promote peri-implant health. And you know that a few years ago, it was not so crystal clear the soft tissue augmentation in terms of real necessity to have soft tissue around our implants and keratinized tissue around our implants. Joe Fiorellini, in another piece of information published in JOM in 2019, said that soft tissue augmentation surgery should be performed around our implants to provide stable keratinized tissue. And adequate keratinized tissue is associated with less peri-implant inflammation. That is a clinically relevant concept. And the vertical and horizontal thickness of 2 millimeters, more or less, become advisable to prevent soft tissue dehiscence, and that was stated by Omli Wang and a good friend of mine, Giovanni Zucchelli, that you know is a master on soft tissue management. And on top of that, tissue grafting in order to correct deficiency, compensation with soft tissue or small concavities, and then increasing keratinized mucosal width and thickness plays a role in preventing what all the clinicians are afraid of: soft tissue stability, recession, exposing of the abutments, and aesthetic problem. So there are two sides of the story: soft tissue stability for aesthetic, soft tissue stability for bone preservation. These are two combined, very important concepts. Then we have a 5-year systematic review, because this is only 5 years mean observation period, less mucosal recessions. And another topic, very clinically relevant: if we don't have the possibility to get connective tissue graft, or we want to minimize the invasiveness of our procedure, not having a donor side, can we use collagen matrix? And are these matrices equivalent to peri-implant, to connective tissue graft in terms of stability, in terms of predictability? And I can say yes, if they stay covered. This is another important issue that we will see during my presentation. And then I should quote the good friend of mine, Linkavicius, that he did a lot of original studies, randomized control studies, and to summarize his knowledge and the message, the clinical message coming from his studies, we can say the vertical and horizontal soft tissue thickness, 2 to 3 millimeters, that's the magic number, horizontal and vertical, for soft tissue stability and hard tissue stability. So these are the two combined type of clinical message that I want to stress with you. And these are the piece of information in the literature, and a very recent one just published in the last issue of the International Journal of Periodontics and Restorative Dentistry, just in 2021. We contributed to the literature with a good friend of mine, Kai Fischer, a German guy, very young, talented periodontist, playing with some matrices on the market, and we did some prospective multi-center case series, and we did in a quite scientific way, superimposing the cast or the scan using our optical impression in order to superimpose and to see the stability, dimensional stability of our augmentation. And if we see the paper within 24 months, we can really say that these augmentations are stable over the time. And we are almost in the way of writing the 5 years result of this multi-center prospective case series. And then with another group from the University of Trieste, we use and we combine two different techniques for soft tissue augmentation using another matrices on the market. One placed over the implants, and as you can see from the clinical picture here is one of the publications. This is a quite stiff type of matrices, and nothing to do with the one that I will be talking about. But we had some experience deriving from these matrices in how to handle and to make the matrices more, let's say, user-friendly, because these matrices on the market usually are very stiff, not so user-friendly in terms of ending properties when you are there. And you know that if you have a matrix that is not really moldable, it does not adapt to the size, and has an elastic memory that returns, you can have soft tissue dehiscences if you have a thin flap on top of these matrices. So from the clinical point of view, to have a matrix that adapts very well to the side is a very important clinical relevant factor. So we compare these matrices, or placing the healing abutment, the old type of guided soft tissue regeneration that was published in the late 90s by Salama to increase the soft tissue, and comparing the two techniques, which is the best according to our study, according to this multi-center study, is better to have a matrices because we have more increase in width and in thickness of the tissue. So we have some even data on this issue. And another critical point for us clinicians, how can we diagnose it, and how can we validate our soft tissue augmentation? Because if you ask a clinician which tool do you use to validate or to diagnose the thickness of the periodontium, it's more of a subjective response, it's not very objective. So with Giulio Rasperini and myself, we had the idea of using colors to evaluate the periodontium. We did with Kai Fischer and a group from Germany some preclinical studies. And we did from a group from Turkey, Aslan Serra, another study in humans, 100 patients, to assess the thickness cutoff of each phenotypes. And as you can see here, you are within a millimeters, 2 millimeters. So the differentiation between thin, medium, or thick, or very thick, you are in this range. And these are very important in order to have unrealistic expectation, because when we use these matrices, maybe it's very different clinically, and only by seeing the patient to really differentiate the thickness. And we know that we are within this range from 0.5 to 2 millimeters, but thin and thick makes clinically the difference. So now let's go in the last 28 minutes left in the clinical use at implant stage. You can use at implant place in one stage. This is the clinical case we start with. Very simple, easy, straightforward. So the phenotype probe allows me to differentiate between thick, medium, and thick by the type of thickness that I have, the flap thickness according to Linkevich's studies, and then I want to combine two surgeries at the same time, implant surgery and the perio surgery, and I want even to correct this type of tissue recession, root recession. I open the flap, I'm doing my periosteal incision right at the beginning of the surgery. I stay within the periosteum. You know that the blade of your scalpel is 300 microns. If you stay within the periosteum, and the periosteum in anatomy, you know exactly that is 150, 200 microns, and you don't go any deeper, you don't have bleeding. So when you do releasing incision and you stay within the periosteum, usually it does not bleed. And then according to Zucchelli papers in 2000, we depithelize the surgical papillae, and then a combination of periosurgery and a combination of the use of Novomatrix, as you can see here, used as a connective tissue autogenous graft, a bilaminar flap to close the two mesial and distal sides at the level of the second premolar in order to increase the height of the soft tissue. And on the implant side, Novomatrix attached to the inner part of my flap. And what we call combination effect, that means soft tissue augmentation, the hardware, platform switching, the subcrestal position, and PRF as was, or growth factor in general, LPRF for boosting the soft tissue healing. And you have seen by the study of Anton Sculean that you can have release of this growth factor up to 9 days. So it will speed up and will boost the soft tissue healing in combination with the matrices. So as you see here, LPRF, healing abutment, and upon healing 2 months after, and you can see the pre-op and the post-op. These are on top of the pre-op measurements, and the post-op, the quantity in height that we have reached, 3 millimeters compared to 1 millimeter. We solved the root recession, but we can validate that from thin periodontal we got to thick periodontal, and we are within that range that I was showing you, because the cutoff of thin is 0.8, and the cutoff for thick periodontal is 1.2 with the standard deviation. So they make, clinically, they make the difference because the probe does not show, and so if it does not show, that means that the tissue will be more stable. On the implant side, we started and we ended up with thick, not visible, very thick periodontium. So we have achieved our goal on the perio side and on the implant side. On the perio side, using the matrices as a normal connective tissue graft with a coronally advanced flap and bilaminar flap. And the case to be continued with our prosto guy. I am the guy who does the surgery, and I got to set the stage for my prosthodontist, and my prosthodontists, they are accustomed now, they are used to have thick periodontium, and in quantity, in height, and thickness. Another combination effect, we start very easy, straightforward, simple solution. This is then what one of my best students, is no more a student, it was the tutor at Lake Como Institute for the workshop today. And we have a combination effect. And the combination effect, that means that we are going to use a Novomatrix to compensate and to, let's say, having a soft tissue augmentation on the horizontal side. The clinical tip to make a Novomatrix that I said is one of the most user-friendly membrane on the market because it's not very steep, it has no memory, but if you want to make it similar to a collagen membrane, you got to soak it in a saline for we do in our offices and in our department more than 5 minutes. We open the box at the beginning of the surgery, and in the middle of the surgery, my assistant knows that he has to change the saline in the vial. And if you want to have, it's not evidence-based, it's just a clinical tip that we do in Milano, is not, as I said, validated by the research. If you want to have the membrane that it looks like a collagen membrane, and you boil the hot saline and you use as a hot sterile saline, the super user-friendly will become extra super user-friendly. It will adapt exactly to the side, and even if you have a thin buccal flap, a thin flap, you won't have the essences because you don't have sharp edges, even if you round them, and you don't have the elastic memory of the matrices. And this is maybe another information that we give clinically to Anton Sculean, and we have to do more research on this specific topic. And then we suture the membrane inside the flap, and then we have the ridge at the same level of the adjacent natural teeth, and we have a thick periodontium, and we aligned the mucogingival junction, because I like to have the teeth, the natural teeth, and the teeth on implants at the same mucogingival junction, and possibly with the same thickness of the ridge on natural teeth and on implants. And you can achieve this goal by reconstructing soft tissue and hard tissue. This is another case, validation of the periodontium, thin periodontium, single tooth application, and to increase and to compensate minor indentation, minor concavities, you can even use Novomatrix that is suture inside the flap. We let everything heal, and upon reopening, we achieve the two goals that we want, realigning the mucogingival junction, same height of keratinized tissue, and the same, let's say, width over here, and there is no indentation, and there is no concavity between the natural teeth and the implants, because every time you have a concavity, if it is an aesthetic sector, in an aesthetic area, you have a different diffraction of the light, so the reflection of the light is completely different, and that can be an aesthetic problem, the famous umbrella type of problem that depicted by Pascual in his publication, or every time you have a concavity, you can have horizontal food impaction. This is pre-op and this is post-op in this application, and this is a video. What about if we leave Novomatrix exposed? So we did a case in which we left intentionally exposed a piece of Novomatrix in an extraction site. We extracted the wisdom tooth, and we sutured Novomatrix as a punch technique, and we left Novomatrix exposed, and in 3 weeks you have resorption of the Novomatrix, and if the patient uses chlorhexidine and it keeps it very clean, you have no inflammation. That's why it's better not to have a Novomatrix of any matrices exposed in order to potentially diminish infection rate, but if it stays exposed, it will resorb. So this type of matrices is better if they stay covered. And this is the case, realigning the mucogingival junction and thickening the tissue, the same two concepts. What about an implant placement two-stage? This is a case of implant placement at two-stage. We measure the thickness of the flap, and we put a Novomatrix, and if we get it covered and it stays covered, this is a 2 months follow-up, and you can see at 2 months even the area of soft tissue augmentation. This is the Novomatrix here. We open for re-entry, and you can appreciate the thickness starting from 1 millimeter, how much tissue we have created on top of the implants in order to achieve that magical number of 2 to 3 millimeters of mucosal channel that you have for having hard tissue preservation, hard tissue stability. And then we took a specimen for doing a biopsy of this case in order for you to understand which kind of tissue you have when you keep covered and matrices over a flap. And this is a case in progress, but we achieved the two goals that we want to achieve on a regular basis for our cases. This is another case for you to understand. This is the planning of the case, and these are two videos that shows you the moment we placed the matrices on top of the implants to thicken the tissue either on the lingual side and on the vestibular side. Can be used like in this case, like you see here, and the second video, and the second videos. In this case, we are doing the releasing, periosteal releasing incision later on during the surgery, and then we cover everything, and then we are going to uncover later on the implants after having managed the soft tissue in terms of height and thickness. What we call combination effect that, as I said, realign the mucogingival junction and having a thick tissue. Or another video showing you another way to suture on the buccal side inside the periosteum, a layer of Novomatrix. On the back, on the lingual side, another layer of soft tissue substitutes, and then suture the flap, and then you achieved with horizontal matrix suture the goal of thickening the tissue on the lingual side, on the buccal side, and on top of your implant. So there are different ways of using these matrices like a poncho on top. And this is another way of having these matrices that stay in place and they do what they are supposed to do. I won't touch the clinical application of PRF, LPRF in details. We will focus on soft tissue healing only. And we published, already accepted for publication, how to increase the soft tissue, how to increase the surgical arches, and how to reestablish the correct fornix. We used to use, in the early days, soft tissue from the patient, but if you need to have a large amount of let's say, tissue, it's better to use a soft tissue substitute in order to minimize the trauma for the patient. And this is a time lapse showing you the healing potential of PRF. This 1 week follow-up, 2 weeks follow-up, and 3 weeks follow-up, almost healed, completely healed. And this is the type of flap, the drawings taken from our publication. And this is a clinical case in which we see on a regular basis less pain and faster healing if you combine LPRF. And this is the type of flap that we use for uncovering implants in the upper jaw, achieving 3 goals: reestablishing the depth of the fornix, and done by this procedure, and on top of that, placing on one side and on the other side a long chunk of Novomatrix that thickens the tissue and makes the tissue more stable. So as I said, I am the one who set the stage for our prosthodontist, and our prosthodontist, they want to have a thicker tissue and a stable tissue. And if you have a removable denture, you can rely on the removable denture and on top of your healing abutments. But at the end of the story, upon healing, you have reconstructed the hard tissue and the soft tissue that allows your prosthodontist to do hybrid prosthesis with a better flow between the arches and the prosthetics. And as you can see, what about using at implant places with guided bone regeneration as a normal membrane, what we do on a regular basis for many years? Again, the matrices for GBR should be fixed, as we saw this morning, can be used with pins. Recently, we abandoned the pins, and we used to glue the matrix over to the bone with a few drops of fibrin sealant. And the fibrin sealant, you know, has been used for years in other fields of medicine, and the cost is the cost of 2 pins, and the Novomatrix stays very easily and very user-friendly, glue and stable to the underlying tissue. And this is LPRF can be used on top of your matrices to boost the soft tissue healing. And as Anton Sculean was telling us, it stays and releases growth factor for 9 days, but at the meantime, as we did in this case, you can close your flap, and if you don't have PRF biotechnology, it will heal, and the matrices anyhow will do what is meant to do: bone regeneration and soft tissue augmentation. So biotechnology will help you there will be an additional benefit, but this does not mean that these matrices cannot be used as a standing alone type of bone and soft tissue regeneration. This is a case in which we have the fractured tooth. The diagnosis, the periodontium. This is after having extracted the tooth, the defect that we have with the exposure of the nerve. And as you can see from this video, we have some bone deficiency, and at the same time, we want to reconstruct the hard tissue, and we want to increase and to achieve the goal of soft tissue management that nowadays are very important as the bone regeneration that for many, many years we focused on. We did an apicoectomy on on the left central incisor, and we did an implant restoration on the other incisor. Okay. Minerox XP, XPY, because we used the porcine type of Minerox XP that it's as a graft material, because the porcine, according to the literature, porcine bone is more similar to natural bone, so we are not going to use bovine, but porcine derivatives. And a Novomatrix glue with tissel fibrin sealant to the underlying bone. And then closure, and then the provisional. This is pre-op, this is immediately post-op with the bone regeneration with the bone graft that we placed. And this is May 21, September, we just recall, and we did some superimposition to let you understand how much bone graft shrinkage you have, and we follow the protocol published by Simone Cortellini and Kirinen in 2019, taking some measurements at 3 millimeters, 6 millimeters, and see the shrinkage of this graft material over the time. And we have an average resorption of this biomaterial, 20% in our cases, with a range of 11, the deviation standard, but at least we achieved the goal of having at least 2 millimeters of thick tissue over our implants on the buccal side. So we have TC evidence, CBCT evidence that Novomatrix clinically can be used like a membrane from bone regeneration. And this is the dark orange is the resorption upon time. And this is, we uncover with a punch and we achieve a 3 millimeter of thick tissue. And this is a case in progress. This is another case, very easy and straightforward. A disaster because the implant touches the natural tooth of the patient. As you can see here, we unscrew the implants, and as you can see, you have the threads of the implant on the poor cuspid of the patient, a young patient. And we use PRF technology, no biomaterials, because we rely upon the papers of Pinto and Kirinen in this case, and this is another, and we wait for soft tissue healing, and for harder tissue healing in a very compromised situation. This is another piece of information just released comparing PRF, normal bone healing with graft and PRF. And this is 2 months, 3 months after 2 months follow-up. Teeth segmentation, because it's a very challenging case in order to do guided bone regeneration. We place the implants, we use Novomatrix as a regenerative membrane, as a regenerative matrix, PRF, close and reopening. This is a CT immediately after the placement, and this is the superimposition showing you same concept as before, that we have clinical evidence that these matrices, they work in the clinical arena. This is the final prosthesis in a very challenging case. Conclusions: do we need adequate tissue around our implants? The answer is yes. Why? In width and thickness, these are the magic numbers for different reasons: less recession, tissue health, and reducing crestal bone resorption. Do we have an objective tool? Yes, we have an objective tool to validate. Soft tissue substitute can be equivalent to connective tissue graft? Yes, if they stay covered, and I hope I... And why to use PRF? Different reasons. If you don't have PRF technology, just look into this new biotechnology. It's more than 20 years that we have been using this, starting with Joseph Chocroun in 2001 when he came from Nice to our office in our university. And there are different reasons, but if you don't have this technology right now, and you use only matrices and membrane, it will heal anyhow. Thank you so much for your kind attention, and if you have any questions, I'm here to try to give an intelligent answer. We don't have all the answers right now. The work is in progress. Send me an email. I can send you all the piece of information that the literature that I listed here. Thank you so much for your kind attention.
Thank you, Dr. Testori.
Thank you.
Thank you for your presentation. That was an incredible way of combining scientific evidence and clinical practice, as usual, because you have shown us that in the history of the cases we have been seeing. Next, I would like to give the scenario to someone that I admire particularly, and it's Professor Juan Blanco. Professor Blanco. So I would like to introduce you to Professor Juan Blanco. Professor Blanco is the head of the Department of Periodontology at the Universidad Santiago de Compostela. He's also the director of the master program and also of the expert in periodontics. Professor Blanco is a past president of the Spanish Society of Periodontology and also of the European Federation of Periodontology. As I said before, it's an honor for me to introduce you to this magnificent person and professional. And his topic today is going to be clinical indications, a new perspective of a new acellular dermal matrix. Juan, the stage is all yours.
Thank you very much, Andrés, as always, for your kindness and your nice introduction. My topic today is to show you how, in a straightforward way, we can use this technology, this new technology. But why we should use this technology? Why this technology is different to the ones that we have already in the market? This is, in my opinion, something that we have to be aware of, and we have to think about it. And then once we understand this, we can go for clinical indications. We have some evidence in some clinical indications. However, there are also some new clinical indications, some new perspectives where we can, of course, use this technology. But to understand why we should use this different matrix, we have to understand how the connective tissue is composed. And we have to understand that there are, in all the connective tissues in the body, two main components. The one is the cellular component, and the second one is the acellular component, let's say the extracellular matrix. And this is very important to understand that this acellular component, this extracellular matrix, is composed of different materials. We have fibers, and we also have ground substance with different proteins. And this is very important because probably here is the difference. Because if we go to understand, if we are able to understand the composition of this part of the ground substance of the connective tissue, we should know that these proteoglycans, for example, are going to be very important in terms of anchors the cells into the matrix and also are going to bind the growth factors. And we have seen in the first session that there are some growth factors that are going to be binded in the Novomatrix material. So probably here is the reason, and I'm going to show you later on why. And of course, we have also some proteins, glycoproteins, such as the fibronectin, the laminin, that they have their own role in the connective tissue. And this role, for example, for the fibronectin is not only to attach the cells to this extracellular matrix, but also to stimulate cell proliferation and, what is probably more important, differentiation. So if we are able to keep these proteins in these materials, probably we are closer to what is natural connective tissue, that they are going to work all together in what we call the connective tissue, as you can see here. And also, in fact, and in addition to this, it's also very important to understand that not all the connective tissue is the same. We have to understand that there is a division, a clear division when we go to the palate, and we have to use the best connective tissue as possible. And that connective tissue is the one who is closer to the epithelium, what we call the papillary connective tissue, because this part of connective tissue in the lamina propria is to be more, or to be denser. So if we go to the literature and review the different kinds of extracellular matrix acting as a scaffold, clearly we have two differentiations, the xenogenic ones and the human ones. In the xenogenic ones, we have the porcine-derived collagen matrices where we only have collagen. They can be non-cross-link or cross-link. And also we have another porcine-derived acellular dermal matrices where they only are composed of collagen again. But if we go to the decellularized human dermis, clearly there are something else in the constitution, in the composition of this kind of matrices. And this differentiation is going to go in the line of the proliferation and also differentiation, acting as biological cues that are very important, considering, in fact, these biomaterials with some inductive activity. And this is already published in another publication in 2015, where the composition of this human dermis is clearly composed of several soluble proteins, but also some growth factors, as you can see here in this table on the right side of the screen. So if we think why is important this Novomatrix, or why this Novomatrix is different, is because its composition. Its composition is not only collagen, is not only elastic fibers, but also they have some proteins. And this is important because they are not going to maintain also, only the biomechanical integrity of the tissue, but also probably they have some biochemical potential. And this is probably the main different aspect when we compare the different matrices, these extracellular matrices between each other. And also, these are some images that you have already seen. If we go for a microscopic analysis, clearly the image of the Novomatrix material is more similar to what is the human dermis. So this is also an important aspect from a composition, a 3D dimensional distribution of the collagen fibers in these matrices. And finally, important to say also is the way all these matrices are going to heal in the body. Because according to this analysis, clearly there are some differentiations, and important differentiations, when we compare the different biomaterials. And the best way that we should go in our surgeries is looking for the same healing as the normal dermis. And this is what the Novomatrix can offer us comparing to the other possible matrices, such as healing with encapsulation, resorption, or scar formation. And let me share with you one of the more recent published study when they compare in an animal. In a preclinical study in vivo, they comparing 9 beagle dogs to different matrices. The one is the mucograph used as a control, and the test is the Novomatrix. And they have used this, studied these matrices to try to do root coverage with the coronally advanced flap, plus one or the other one biomaterial, these acellular dermal matrices. And you can see that there are some outcomes that were analyzed: clinical outcome, histological outcomes, inflammatory response, and local tissue reaction. So if we go to the results of this study, clearly in the right side, you can see that from a histological point of view, in terms of integration and adverse events, there are no differences. All these matrices, the behavior of all these matrices in terms of adverse events and inflammation and integration are very similar. However, if you go to the histomorphometric analysis, clearly, immediately the result is the same. But according to this study, in the 6 weeks term and in the 10 weeks term, there are important differences between the two matrices. So the conclusion clearly says us that the Novomatrix group provided greater root coverage than the control, and also tissue thickness at the end of the follow-up period. And not only we have information from preclinical studies, as we saw with this study in vivo and also in vitro by Professor Sculean, but also we have some information coming from the allograft dermal matrices. From a clinical point of view, in this 3 studies, clearly we can see that there is no difference in terms of root coverage when we use a connective tissue graft or an acellular dermal matrix. And probably the key issue is the relevance that the trap of these biomolecules, let's say the growth factors, and also these glycoproteins are so important for the well behavior and the well treatment of these biomaterials. And in addition to these papers, very recently has been published a systematic review for root coverage procedures treating localized and multiple recession type defects. And in the conclusions, clearly we can read here that the cellular dermal matrix graft appear as the soft tissue substitute that may provide or can provide the most similar outcomes to the one achieved with the connective tissue graft. So, dear colleagues, we are in front of something that probably is going to change our clinical practice. And that is what I'm going to show you in my next slides. I'm going to show you different applications, but these applications are going to be easy applications because I think that we have to start understanding what we have in our hands and how we should manage from a clinical point of view, and not only how we are going to deal with the incisions, the surgery, and so on, but also how we have to manage these biomaterials. We have to bear in mind that these aspects are very, very important. And I am going to show you this first clinical case where we have a case with a multiple recession. And according to what we have heard this afternoon, this evening, from the other colleagues, according to the paper by Giovanni Sculean and Massimo De Santis in 2000, we proceed with the surgical aspects and the surgical design of the incisions that they have designed in their paper. So we measure the different depth of the recessions. We go for the central recession, that is where all the papillas are going to rotate. We have to perfectly understand and to see where is the cement enamel junction, and we proceed for the different incisions. I'm not going to explain the incision, it's not the objective of this presentation. We have to do these angulated incisions according to the depth of each recession. We go for the full split flap. We lift the flap according to this full split thickness flap. And once we lift the flap, we clean the surfaces of the roots, and also we have to depithelialize the anatomical papillas where the surgical papillas are going to be sutured on top of those. We now proceed for the root coverage. We use first this Novomatrix, this cellular dermal matrix. It is very important, as we do with the connective tissue, to perfectly fit these biomaterials. These biomaterials have to be sutured to the immediately tissue. So we have to tissue this to some periosteum that we have led in some places below this, behind this biomaterial, this membrane. We go for the suture, as you can see here, and finally, we proceed for the advancement of the flap. And then with sling sutures, we suture everything, we cover everything. In our opinion, it's important to cover this Novomatrix, this membrane, to avoid not only resorption of the Novomatrix, that's clear, but also to not get the risk of possible infection. This is 3 months post-op. You can see before and after, and I would like you take a look to the keratinized gingiva before and after 3 months. Because when we see the picture 3 months later, this means a 6 month follow-up, even the keratinized tissue is going to increase, not only in thickness, but also in height, as you can see clearly here. 6 months follow-up, 6 months healing. And we go again in the same procedure, with the same procedure to the left side of this patient. We do the same surgery, we clean everything, we epithelialize the anatomical papillas, we place the matrix membrane, and with sling sutures, we coronally advance the flap. And this is 3 months post-op. And you can see here in the left side, the pre-op and the 6 months post-op, where clearly there is an increase in this keratinized tissue. Also the same for the left, but the left is only 3 months post-op. So, dear colleagues, we are, again, not only increasing the thickness, but also the width, the height of this keratinized mucosa. Another application where we can use these matrices is clearly, and this was mentioned also by Professor Testori, is when we have thin mucosa and little keratinized mucosa. So in this case, very easily, we can place a membrane in this way. We can make a hole, and we can, as a punch, and we place the membrane covering the buccal part and also the lingual part. Then we suture, avoiding the exposure of the membrane. We suture everything. Everything has to be very tight around the 2 implants, avoiding, again, the exposition of the matrix. And this is 1 month post-op. And what I want you to take a look is to the mucosa, where you are seeing in the vestibular aspect. It seems that the alveolar mucosa has a different clinical aspect, let's say, because probably from an histological point of view, we have to wait for the paper by Professor Testori in terms of the histological analysis to check how is that connective tissue. We can see also the lingual aspect, where we have almost also a very nice keratinized tissue around the implants. And according to this paper, I want again to pay the attention for you and take a look to this important clinical aspect. Sometimes we don't see keratinized epithelium in the mucosa, and we immediately think that this mucosa is going to be mobile. But according to this paper, this kind of matrices has the property of increase the immobile connective tissue beyond the mucogingival line. And this is also an important aspect, because this is a clinical measurement, a clinical outcome that for sure has to be corroborated with histological analysis. And this increase is going to be around 2 millimeters and a half. And this is once the mucosa heals, and finally 3 months post-op, where you can see, particularly in the occlusal view, where you are seeing clearly the increase of the volume of this mucosa, and probably also this immobile connective tissue beyond the mucogingival line. You can see the X-ray to check the peri-implant crestal bone. Also, another application, and I'm going to share with you this case, is maybe in some situations where we don't have keratinized mucosa around the implants, but the implants are already installed. And the patient comes to the office with inflammation, pain, bleeding on probing, a slight bone loss, so let's say, and define this as a peri-implantitis, and little keratinized width and thickness. So we have to go to clean first the surface of the implant. We have to clean the defect, eliminate the granulation tissue, also to polish the surface of the implant, and then to increase this keratinized tissue, we go for a membrane. a Novomatrix membrane that, in the same way I saw you before, we make a hole with a punch and we stabilize the membrane with the own implant. On top of this, once we suture everything, we place the crown of the patient. Everything heals, and here you can see how thick is now the mucosa, and all the symptoms have disappeared. But the important thing here is how healthy is this mucosa in terms not only from a clinical view, the clinical aspect, but also the thickness and the increase of width of this keratinized tissue around the crown of this patient. And take a look to the X-ray. The X-ray now has a better look than was clearly before. So the objective of the treatment is completely achieved in terms of we were able to eliminate the pre-implantitis, the infection, but also improve the healing of the soft tissue that probably is going to offer us a better prognosis in the long term. Let me share with you another application that already has been shown by my colleagues, is to increase the volume. But for increasing the volume, sometimes it's enough with a connective tissue graft, or why not, a Novomatrix, such as in this case. This is a patient with a deciduous lateral, the number 12. We have to extract this tooth, and of course we're going to install immediately an implant. We proceed with the normal surgical design, as we always do. We clean everything. It's very important to eliminate all the remnants in the bone, in the surface of the bone. And then we proceed as we normally do to install the implant at the same time the definitive abutment. So we usually go for the one abutment, one time approach. It's very rare that we use submer technology, just in cases where the primary stability is not good, or we need to do such a big regeneration, bone regeneration, that we need to cover everything to avoid risks, for sure. Then, once we do this, we proceed to design the shape of the membrane to have a nice shape to be adapted to that defect. And once we adapt the membrane, we close very easily every part of the flap until we have finished. And this is the convexity that you can see in the vestibular aspect of this implant. This is 10 days post-op with a provisional prosthesis 3 weeks post-op. This is the X-ray. And this is how it looks before preparing the final crown. So you can see clearly how the gingiva, how it looks perfectly, the gingival margin, the scallop part, everything is correct. And we were able to eliminate this concavity that we had before the surgery. And let me share with you this last case. And this last case has been done this morning. So this is very fresh. And in this case, we had a patient that had their canines included. These canines had to be extracted 6-7 months ago. We went for rich preservation with Alpuref block, and then once these 6-7 months went away, and once the orthodontic treatment allow us to do the surgery, we proceed today for this surgery that I'm going to show you immediately. I would like to pay your attention to the collapse that we have in the vestibular aspect. An important thing is how are we going to treat this? With soft tissue, with hard tissue, or with both? It is going to depend on the treatment plan. And this is very important to understand that this is the one who is going to show us if we should go only for soft tissue or both, hard and soft tissue. And clearly in this case, the position of the implant in the vestibular aspect is in a very risky situation because the thick of the buccal table, of the buccal plate, is going to be very thin. So clearly we have to go for both hard tissue augmentation and soft tissue augmentation, like the image you are seeing in the screen. You can see clearly the ridge. The ridge is very thick. However, the implant, this simulation indicates that the implant has to be placed a little bit vestibular according to this 3D planification. So in these cases, dear colleagues, it's very important to increase this vestibular bone. Otherwise, we are going to have a very thin a vestibular aspect, and then probably we are going to have, after the remodeling, we are going to have some bone resorption in the vestibular side. So in this case we proceed with a Conologue progressing line implant, 3.8 in diameter and 11 millimeters in length. The abutment, it was 2.5 millimeters. This is the vestibular aspect where the implant is going to be installed and how the implant is going to be finished after installation. We use some biomaterials also, these Novomatrix biomaterials in terms of the membrane and the minerals in terms of the hard tissue substitute. And I'm going to show you this video of this surgery. It takes 3-4 minutes. This is once we lift the flap, a full thickness flap. We try the surgical stent and we measure everything, particularly the apical position of the implant. This is very, very important. In my opinion, the surgical stent in these cases of a single gap, the important thing coming from the surgical stent is where we are going to leave the implant in an apical direction. So we proceed as normally we use, and we do. We check the parallelism, we check the direction, we check everything according to this surgical stent. We go with the different bars, and clearly we can see that the vestibular bone in the crestal zone is very thin. Even in cases where we don't have any dehiscency, we have to go for increase and for bone augmentation techniques. We install the implants very gently, very easy way. We control the torque of the implant because we want to go for immediate loading also. We open a little bit the space for placing the abutment, and the abutment is perfectly installed according to the right torque that the abutment needs to be stable. We proceed now to, as we normally do, to make some perforation in the cortical bone to reach this bone marrow where the indifferentiated cells are. You can see how the blood comes from the medullary part of the bone, and clearly this is the bone marrow. We clean, this is very important, we clean the membrane. We still don't know how many times we need before going to the installation of the membrane. We use the Alpuref block, as you can see here clearly. We look for the benefits of every biomaterial, not only the bond substitute or the membrane, as you can see, but also some biological proteins that come from this LPRF material. We fix this membrane. It's very important to have this membrane very well adapted and to avoid mobilization of this membrane. So, so far we use titanium pins to fix this membrane and to adapt it perfectly to the defect. And on top of the membrane, we go for these LPRF membranes. So we go for both combination. And according to the papers by Anton Sculean, probably this is the best choice to do the right things. One, to obtain guide bond regeneration. The second is to increase the thickness of the flap, because we use this membrane, and also we are using biological and active proteins that are going to be trapped on the membrane, and they are going to suffer a slowly release in time. That is very important for the good healing and also for the good result of this patient. Finally, the patient went for the prosthesis room, and this is the X-ray once we finish the surgery. And finally, you can see the immediate loading that was done by our prosthodontics, that she is Iria Darriba. You can see the vestibular view and also the occlusal view that this case was done this morning in a hands-on workshop that we have today. So with this in mind, dear colleagues, I go for my conclusions, and my conclusions are very clear. This is a new product, probably a new advancement in something that is important, because we have to think biologically, we have to understand how the natural tissue works, and we have clearly to imitate how the natural tissue works. And probably today, the more similarity in terms of proteins, in terms of different proteins and fibrins and so on, probably, and fibrils, probably the Novomatrix is the most similar for soft tissue management. So the conclusions are that these biomaterials clearly can be used in easy situations like root coverage, increase keratinized width or height, and also to increase the volume. But also there are more indications that for sure are not well scientific demonstrated. So we have to go on working in new perspectives, in new indications, but however, several clinicians have some experience, like Professor Testori, like Anton Sculean, where some indications can be introduced in our clinic, such as the treatment of peri-implantitis, like the case I have shown you, and also for the GBR technology. So with this, I finish my presentation, but I would like first to thank to SEPA and also to Biohorizons Camlock for his or their support in preparing this session, and also thanks to all of you who are, most of you, online. Thank you very much.
Thank you, Juan. As usual, you never disappoint in transmitting your knowledge and experience. Now we're going to pass to the round table and the discussion and questions. So I would like to invite the speakers that we have here with us and Dr. Sculean online. Okay, so we're here. Again, I would like to thank all the speakers for their presentations, and also BioHorizons Camlog for the sponsor of this session. We have a few questions. First of all, this one is for Professor Sculean. Professor Sculean, what is the importance of effective soft tissue management for implantological treatment success? What is your opinion about this?
Well, what do you mean now with the question, with the importance? Whether we need soft tissue or whether we need keratinized attached mucosa or?
I understand most of the quality of the soft tissues around implantological, about dental implants.
Okay. I mean, we have data from the literature suggesting that we may improve the long-term prognosis of the implants if we do not only have sufficient bone surrounding the implants, but also sufficient attached and if possible even keratinized mucosa of at least 2 millimeters, that's the value in the literature, or even more, especially in the posterior areas, that's very important. And also the thickness of the soft tissue should be appropriate, otherwise we may face certain resorption of the bone. Of course, if we have stable soft tissue that doesn't move, then the patient has an easier access to clean. Of course, in the frontal area and the aesthetic area, we have also some other indications like improvement of the so-called red aesthetics. But first, if you look at the health, that's very important.
So according to the information that has been presented today here and by all the speakers, and knowing that substitutes like Matrix are giving us or providing us an important new treatment, what do you think is your opinion in the trends in the future? What do we need? What do we still need from this Matrix to work better?
I mean, we have to be aware that the matrices are still not living tissue, and they are lacking cells, they are lacking growth factors, and I think that's very important to realize. You cannot expect a miracle from a tissue that doesn't contain cells and growth factors. So for me, these matrices are really a very nice new alternative. They open new perspectives, but we should use them for clearly defined indications, and we should use them as a carrier for cells, for growth factors, and even if you would use them, for example, for an open kind of healing, to increase, for example, the width of the attached mucosa, be aware that you still need cells that are able to recolonize or to colonize these surfaces. In other words, you may need even a certain width of attached keratinized tissue, because if you don't have these cells, they cannot grow. You know, from nothing, nothing will come. So they are scaffolds, and you should use it in a way that you embed it in your clinical armamentarium and clinical treatment strategy.
Okay, so linking your response, I'm going for the next question. This one is for Professor Blanco. We have seen an evolution in the use of different blood-derived. What do you think is the success that we are achieving in the use of LPRF, and how do you think this can be improved in the future too?
Thank you for the question. Well, clearly there is an evolution from the first regeneration of platelet concentrates to the second generation of platelet concentrates. So there is an important difference, in my opinion, to be applied in dentistry. That is the density of the fibrin that we are working on with this LPRF. For me, this is a very important issue. Also, these membranes are able to keep some important cells. This is the platelets and also the macrophages. This is very important. Not only leukocytes, neutrophils, for example, but also macrophages. And because the macrophage, the M2, is where there is going to be a pivotal a change in the healing from the inflammatory side to the healing side, or the reconstructive or regenerative side. And also there is, in addition to this important aspect, is the slow release of these growth factors. We have done a study, the proteome of these LPRF membranes in our labs with this mass spectrometry. And we have studied 3, 7, and 21 days. And we were able to demonstrate that at the third day, we could find coming from the LPRF, after washing the LPRF, we incubated this LPRF, and in the third day, we were able to find 700 proteins. And those proteins are produced by the cells that are living in that LPRF membrane. And this is very important. And during the 7 and 21 days, these proteins were changing. According to the process of the healing. And this is very important to understand. Professor Sculean was talking about 5-4 growth factors. But 5-4 growth factors are very important. But we have a huge number of growth factors and a huge number of proteins that they are acting together. And I think there are many aspects that we still don't know about the LPRF. But, well, the research is there. We are working, and we are going to go on working because we are very keen on, like my colleagues, in this nice therapeutic approach. So clearly, 2 or 3 aspects: the density of the fibrin, the different types of cells, and the capacity of a slow release of these proteins, because we don't have only growth factors.
And considering the easy technique and that it's not complicated to do it in our daily practice, do you think we should include the LPRF in all our surgeries, or is there any particular indication that you will indicate?
Well, there are many indications where we don't have any data. This is first. Second, is an autologous product without any addition of anything. And is another advantage also, in addition to the proteins and so on, is that it's very reproducible. And this means that it doesn't depend on the human being when we are preparing the LPRF. This is an important difference, because we are going to use a homogeneous treatment with our patient always. What's happening? That we don't have data for all the indications. But currently, there are indications clearly demonstrated where we have some added value. This is rich preservation. This is soft management, let's say connective, soft tissue root coverage, sinus lift, LPRF block in horizontal and vertical bone augmentation. So I think that we have to wait clearly for the evidence, but there are some clinical situations that are appearing in the literature where we are obtaining clearly benefits when we use this LPRF. So most of the times, let's say, I use it in my patients.
Thank you, Professor Blanco. And last but not least, we also have questions for Dr. Testori. And the first one is that what are the differences between the AVM and the human allograft AVM that is available in the USA in terms of the chance to improve the height of the keratinized mucosa around the implants? I think that the question goes of an allograft or the porcine material that we're using now.
The only problem that I have with this question, first of all, I would like to thank you, SEPA, and I would like to thank Professor Blanco for hosting me in his office, beautiful office. It's like an hospital, and I learned so much from your surgery. Thank you so much, and I really feel at home here in Spain. And I would like to thank you, even all the staff from BioHorizon Camlock. And we have been using allograft for a long period, but then it was withdrawn from the market. And we were very satisfied in Perio, in our department, and in the clinical use of Allodorm. That is human source, and then the only available product that now we have in Italy is from animal source. So we haven't run any comparative study, so I can give you my experience, my opinion, with a limitation of my opinion. It seems to me that its work is, there is an equivalency in the use of Allodorm and Novomatrix, but as I said, we don't have any study. This is my clinical observation, with the limit of my clinical observation, taking into account that I have 40 years of practice because I graduated in '81, so I've done in these 40 years a few cases. So it seems to me that my clinical experience says that the two products are equivalent in terms of clinical outcome.
Okay, so considering that you have so much experience with this material, which are the most predictable indications that you would recommend for the use of Novomatrix?
The predictable indication that we use for Novomatrix are the ones that Professor Blanco was just showing, mainly what we have today in Perio, evidence-based, what we have around implants. It's a kind of off-label use, the one that we use in guided bone regeneration, but I was very pleased to listen to my mentor, because he's always a mentor for everybody of us, Anton Sculean, is a Wikipedia as we think of science, and the Wikipedia said that most probably in combination with PRF, and as a rough clinician I learn a lot from Anton and from Blanco, I am on the right track for this new indication. And according to my rough experience, it's opinion with limitation, it works right now, even if you don't have the PRF technology, but I think every clinician should look into it and start with this PRF technology as we started 20 years ago, because Shokrun came to our office in 2001. So it's 20 years of non-evidence-based use of PRF, but clinically it works. And now, sometimes we must admit that clinical use is more advanced in terms of science. We do our experience and then we build the science behind that. We have an intuition, we do that, we had the opportunity to use Novomatrix. Off the label, we use Novomatrix as a membrane. It works, it seems that it works. Do we have the evidence? No, but in the right hands, it seems that it works. But if you want to be on the safe side and wait for the evidence, you should stick to the indication that Professor Blanco was just telling you. But sometimes you have a patient sitting in the chair, and I think if a technology, a biotechnology, does not violate the rules of biology, let's use it. Otherwise, we should wait and tell to the patient, it's not evidence-based, return in 5, 10 years. I don't have this possibility, so I treat the patient if it does not violate basic science.
So from a wise point of view, it seems that we need to continue trying with these materials and generate doubts and create science in the future, right?
I think so. This is my personal opinion.
It's also mine, and I'm sure that Dr. Sculean also shared this.
And I was very pleased because every time I listen to Anton, he gives me a piece of information, tell me we are on the right track.
Excellent. So, unfortunately, we don't have much time left. We have to finish because there's other things that still need to go on. I have to thank Dr. Sculean, Professor Sculean, Dr. Testori, Professor Blanco. Thank you for your time, thank you for your knowledge, and thank you for sharing it with us. I also, again, want to thank you, Camlock BioHorizons, also the Spanish Society of Periodontology, for inviting me here and be the moderator of the session today, and a special thanks to the whole technique team that has been here with us today. Thank you very much, and see you tomorrow.
Thank you.
Bye-bye. Thank you so much.
Bye.
Thank you.
Thank you.